morning, good afternoon, everyone. Welcome to the Nestlé Health Science Online-Symposium on the nutritional management of pediatric Crohn's disease. This symposium was initially programmed at the World Congress of Pediatric Gastroenterology, Hepatology and Nutrition to be held in Copenhagen, and that was unfortunately cancelled because of the COVID-19 pandemic. Fortunately, we could maintain this scientific activity online. So let me introduce myself. I'm Professor Paolo Leonetti from University of Florence, Mayer Children's Hospital in Italy. I will introduce this symposium on nutritional management of pediatric Crohn's disease. Then we will listen to a talk by Professor Javier Martín de Carpi from Barcelona, Spain, on different approaches for the induction and maintenance of remission in pediatric Crohn's disease. Then a famous dietitian, Rotem Sigal-Bonet from Holon, Israel, updates us in the dietary management of Crohn's disease with the Crohn's disease exclusion diet. Can we predict patient's response? And then the last talk will be by Professor Ethan Wine from Edmonton, Canada, from theory to practice, clinical use of Crohn's disease exclusion diet in real-life cases. During each presentation, you can start to ask your question using the widget next to this video. We invite you to do so to make this symposium fully interactive. You can also vote for the questions. This question will be addressed during the live Q&A session that will follow the presentation. So let's start my introduction. You know that almost 25% of the onset of IBD is in pediatrics, children and adolescents. Crohn's disease is a complex systemic condition. Regardless of the underlying genetic predisposition, a growing body of data implicates an interaction of mucosal immune response with commensal gut bacteria. And we know that diet is able to shape the gut microbiota. So I will show you some data, how diet can shape our microbiota. We did years ago a study on a population of children living in rural Africa, in Burkina Faso. And the main component of the diet of these children are cereals and legumes and a lot of fiber. And when we compared the characterization, the composition of the gut microbiota with the microbiota of children living in Western country, in the city of Florence, Italy, there were two completely different worlds. From one side, we had the African children, on the other side, the Italian children. Only 5 children had something in common. They were those who had still some breastfeeding, and they had in common the Bifidobacterium genus. And looking at the level of species, the African children had a lot of bacteria, or bacterial species, able to extract metabolic energy from ingested plant polysaccharides. And we know that the consequence of this is the production of short-chain fatty acid. And they had a very high concentration in the stool of short-chain fatty acid as compared to the Italian children. And we know that short-chain fatty acids improve epithelial cell energy, metabolism in colitis, reduce inflammation in colitis. They are actually fuel for the colonocytes. And we know also that the prevalence of IBD in that population is very low. More recently, we looked to the effect of urbanization. The same kind of population, the same ethnic group moving to a small town, a dirty small town, or in the capital city of Ouagadougou, where you can find every kind of Western food. You have a supermarket and so on. The diet completely changed, increased the calories, decreased the fibers. They still have the health problem you have in an African countries like malaria, infectious diseases. However, the composition of the microbiota change, and also the level of short chain fatty acids in the stool decrease progressively to the level of European children, and also the microbiota change completely, going to be very similar, especially for those from the capital city of Burkina Faso, very similar to the one that we found in Italian children. So what are the characteristics of Western diet? Low in fiber, rich in total fat, animal protein, polyunsaturated fatty acid, digestible refined sugars, and this can alter gut microbiota composition, resulting in dysbiosis, which increases the intestinal permeability. And there is some evidence now that can cause low grade of inflammation, and in a genetically predisposed individual, maybe he can get IBD or Crohn's disease. There are experimental animal models, significant role of dietary components. So there is, for instance, the disruption of intestinal mucus layer by emulsifier, or activation of inflammatory cascade by specific sulfur-producing bacteria. And we know that high-fat, high-sugar diet alter intestinal barrier function in rodent models. A carrageenan that you can find in our food disrupts normal intestinal epithelial function. There is also some evidence in humans. This is a very big epidemiological study on 170,000 nurses of the NHS in UK, followed for 26 years, and 269 nurses developed IBD, and women, they were all women. Women in the highest quintile of fruit fiber intake had a significantly reduced risk of Crohn's disease compared to those in the lowest quintile of fruit fiber intake. And here is summarized the potential mechanism underpinning the relationship between diet and IBD. If you have a Mediterranean diet rich in fruit, vegetables, whole grain, you have a microbiome diversity, an intact permeability of the barrier function, and the immune function is balanced. Whereas if you have a Western diet, you can have easily a dysbiosis. There is an impaired permeability of the barrier function, and then you can have a loss of tolerance if you talk about immune function. Then, going back to pediatric IBD, have we changed actually the natural history of this condition with biologics, for instance? Considerable debates exist as to whether the risk of complication need for surgery has truly decreased. There are good data anyway. A recent systematic review and meta-analysis reported that after the year 2000, the surgical rates at 1, 5, and 10 years have significantly decreased. However, it is unclear whether this decrease can be solely attributable to the introduction of biologics, the more effective use of type urine, or perhaps the early disease recognition and early use of effective intervention. And that anyway, we know that progression of disease occurs despite reduction in inflammation, because our drugs are actually maybe less effective than we believe, and each biologic controls only one pathway, so other pathways come into play, leading to disease progression. Maybe we are not treating the factors that drive inflammation, allowing disease progression. So these are questions. And one example is that it is shown that early anti-TNF-alpha therapy, for instance, will prevent internal penetrating disease, but not stricturing complications. So this is our strategy. You know, these pyramids are very famous: conventional step care, accelerated step care, early top-down. But as a first-line treatment in pediatrics for Crohn's disease, we use exclusive enteral nutrition, and this is clearly stated in our guideline. Now there will be a new version, but the last versions, the statement 1 is exclusive enteral nutrition is recommended as first-line therapy to induce remission in children with active luminal CD. And partial enteral nutrition should not be used for induction of remission. I would like to remind you that also it is important that nutritional status should be optimized before surgery by using enteral nutrition, for instance, but for some patients who need TPN. Here is a list of all the studies that has published on exclusive enteral nutrition, the remission rates. So there is evidence of efficacy of exclusive enteral nutrition, so exclusive liquid diet. However, we know that individuals, including children and adolescents, prefer to eat real food over an exclusive liquid diet. Substantial barrier exists to the adoption of formula-only approach. And we know that normally exclusive enteral nutrition is not accepted by adult patients. And here I just put a list of different exclusion diet has been proposed for the treatment of Crohn's disease. And there is no doubt that the higher level of evidence has been shown by the Crohn's disease exclusion diet. We have 2 open studies published and more recently a randomized controlled trial. So in the following talks, you will hear more about the dietary management of Crohn's disease and the use of Crohn's disease exclusion diet in clinical practice. Thank you for your attention.
Thank you very much for the invitation to participate in this webinar. This is my talk on different approaches for induction and maintenance of remission in pediatric Crohn's disease. You can see here my disclosures. So to begin with, I would like to remember what are our objectives when treating pediatric patients with Crohn's disease. Some of them are quite similar to those of adults, as to induce and maintain long-term remission, to avoid surgery, to reduce hospitalization, and so on. But some of them are quite specific for our pediatric patients, as to preserve growth and to maintain an adequate nutritional status. So what should we expect from pediatric Crohn's disease therapies? Well, this could be our desire to have some treatments that have rapid onset of action, that are effective with absence of side effects, either safe and long-term durability. So we could say that with what we need is some kind of real treatment. So these are our guidelines for pediatric Crohn's disease, both from the ECHO and the ESPGHAN. All of you know it. And as you know, in these guidelines, it is contemplated that many, even most of our patients, even those with severe disease, could be treated with exclusive enteral nutrition for 6 to 8 weeks. Of course, these guidelines also has some special consideration for some patients with special situations, with complicated disease, or even with risk factors for bad prognosis. As you can see here, those patients would be treated or could be treated even since the beginning with biologics. And these guidelines were the first ones that contemplated this direct treatment with biologics even earlier than the guidelines from adults. But anyway, let's come back to exclusive enteral nutrition for many of our patients. So why do most of us or many of us choose exclusive enteral nutrition as induction treatment? Because we know that this therapy has shown its efficacy in induction of remission, so we believe this is effective. We feel very comfortable defending this option in our patients because we accept this is our first option. We know also that it helps to recover the nutritional stages, so we rely on it. It avoids all the treatments with side effects. We trust in it. And although it can be difficult for the patients, we can manage it better with a multidisciplinary team involved. But our feeling is that we succeed with this treatment. But our real-life practice is that very few patients will maintain remission without treatment after induction. So we have to start other maintenance treatments or strategies after exclusive enteral nutrition. Our experience tells us that not so few, but not so many neither, maintain midterm remission and immunosuppressive treatment as maintenance therapies. So we can't rely on this strategy in the long term. And at the end, we know that we have other drugs that are quite effective, fast-acting, relatively safe as anti-TNF drugs. So most or some of our patients will need to change our strategy of maintenance with immunosuppressant to this anti-TNF. We will have to escalate or accelerate or step up or whatever we want to call it. So this should be our classic way to the top, as I told you. So once we have initiate maintenance therapy with some kind of immunosuppressant as thiopurines or methotrexate, and it fails. So after changing from one to another, trying to get the response, even if it fails the second one, we can escalate to anti-TNF therapy, as we are quite used now in our patients. We know it has better results when used at earlier stages. We know that not all the scenarios need the same strategy. As for example, we know that we need higher doses and higher levels for perianal disease. We know also that we can improve our results with different strategies as therapeutic drug monitoring. There are different approaches as treat to target that we know is quite promising for treating our patients for obtaining a better results, a better prognosis. And we all know also that combo therapy can be useful in some patients. So we have to balance between risk. We are quite used to balance between risk and benefits of those treatments in our patients. But don't forget that in the long term, some of our patients will fail anti-TNF, both primary or secondary loss of response, and will require a new approach. Some of our patients will need surgery in the future or will have complications. I always say that we as pediatricians are quite lucky because we don't see many complications in our patients, but our patients will have it in the future. But the thing is that we don't usually face it, and it's faced by our colleagues. So some patients, even treated with anti-TNF, will need something more because it can fail. So what we usually do, or what we are doing now, is jump to the next step. There are some experience with the new biologics in pediatric Crohn's disease or pediatric IBD, as you can see here, vedolizumab or ustekinumab, and even there are some emerging literature about combining biologics, as you can see here in this study from Norway, in which they combine anti-TNF with vedolizumab or with ustekinumab with good results. But even after all these changes, some of our patients will go to a non-exit road because once we are in the top of the tops, we can't do more for our patients. And this is a very difficult situation because I'm convinced that we as pediatricians have an important role for the evolution of the disease in our patients, because depending on the balance between remission and inflammation that we can get in our patients, many aspects of the disease or even their lives will depend, as surgery, hospitalization, disability, toxicity, probable cancer, infections, final aid, radiation, bone mineral density, even their life expectancy. So we have to try to offer them new strategies to control the disease. So we still need a different approach that can be permanent, with permanent effect, avoiding complications, and at the same time to be safe and satisfying for our patients. So we need something more. And I'm convinced that the question is not only having different therapeutic options, but to know how to get the most of them. And it's important to find the most suitable treatment for every patient. I don't believe there will come one day in which we have a drug or a therapy that is okay for all of our patients. So we have to individualize very much the treatment for every patient. So I like to think in IBD also as a not one direction disease, because it seems like, as I told you, we are going to the top, and once you are in the top, you can't do anything more. And the thing is that maybe we can use previous treatments, or we can think of imaginative strategies that we could have used before. And sometimes we should consider coming back to basics, and this is what I'm going to tell you. Because if in a very simplistic way we understand IBD as this combination of genetic predisposition with host immune system and microbiota and environmental factors, most of the treatments we use, as you can see here, what they do is to stop the reaction of our immune system to that causes the inflammation. So we are in some way blocking the response. But if we treat and we use diet in our patients, what we are doing is to stop all this combination or all these links that can cause the disease. So as you know, because all of you know about new studies with Crohn's disease exclusion diet, this could be a new nutritional strategy for our patients. It has shown equivalent efficacy as compared to exclusive enteral nutrition in induction of remission. And we know that in a selected group of patients can benefit, these patients can benefit from nutritional therapy, and not only in the first stage. It has better tolerance and better adherence than exclusive enteral nutrition. And the important thing that I have told you previously is that we intervene not on immunological mechanisms of damage, but probably on its pathogenic trigger. And these open new scenarios of intervention. As you know, the previous studies by the group of Ari Levine, it has shown even better efficacy than exclusive enteral nutrition, but also it has shown efficacy in complicated scenarios. Because until now we were used to use diet in the first stages in non-complicated luminal disease. But the experience is growing about using it and having good effects or good results even in patients with complicated disease or with a loss of response of previous treatments. So another important thing is about the diet is that we all know that it's a real worry for many of our patients. So can we think of how many of our patients' families ask us about the role of diet when we diagnose them with IBD? So almost all of them. And what do we usually tell them about diet implications? Because up until now, what we usually did was to say, well, after exclusive enteral nutrition, there is no reason to modify your diet because there is no any single food that has shown to be implicated or directly involved in the disease. And also think about how many of our patients do some kind of a special diet or will do it in the future. And most of these diets will be even restrictive and not very healthy. And also as pediatrician, I think we have always a good opportunity every time we talk with our patients about diet, about healthy diet, it's a very good opportunity to actively participate in a better way of life, in a better, even in the treatment. So, of course, we should offer to our patients access to efficient treatments, experience and capacity for using them properly, multidisciplinary teams, a closed system for the follow-up, accessibility and connectivity, but also we should give them the tools for autonomy and self-care. And this is important because we are facing now a very new situation with the pandemic, and one of the things we have learned is that our patients should maybe now more than ever have the tools to manage the daily life on their own, be able to intervene in their disease with less direct assistance from us, and actively participate in the self-care, and to manage the disease on their own instead of receiving or collecting drugs in the hospital, because many patients would probably better adhere to its own decision linked to lifestyle changes than to impose drugs. Thank you very much for your attention.
Good afternoon, everyone. I would like to thank the organizer for the opportunity to be today, and also would like to thank you for joining us for this important and interesting session. And you heard great presentations so far, and today I would like to present you and give you some updates in the dietary management of Crohn disease with the Crohn disease exclusion diet. And specifically, I would like to focus on the question, and if we can answer this question at this stage, can we predict patient's response? And those are my disclosures. So let's start. And I would like to start this presentation with a slide from a review that we published in Gut in 2018 with my colleagues here, Eitan Wine and Ari Levine. And this is actually the main mechanism of the diet. And what we can see here is a healthy gut compared to Crohn disease gut. And I would like to show you some observations that we can see the differences between the healthy and Crohn disease gut. And those observations are presented in animal model, and I will explain in just in a minute. So the observation that we can see here are the loss of diversity and dysbiosis. We can see here how the differences. We can see the low butyrate and mucosal bacteria. We can see the thin mucosal layer compared to the healthy mucus there. We can see the bacterial biofilm and also the loss of butyrate receptor, the GPR43 receptors. We can see the tight junction breakdown here with the gaps that are compared to a normal healthy gut. We can see the decrease in the fencin here and also the bacterial translocation, the red here. We can see the decrease in Tregs in the immune system and the defective bacterial clearance. At the end of the day, all those observations can lead to inflammation. And what is interesting is that all those observations in animal model shows that there are several dietary components that potentially can cause those observations. So the main mechanism of the diet is to try to exclude those dietary components that might be pro-inflammatory, and by excluding them, we might be able to reduce the inflammation. So what are those dietary components? And for the same review, this is a nice figures that we show that the studies that show the effect of the diet, we can divide it, the diet effect, both the host in terms of the barrier function and the innate immunity, and also the microbiome. And what is interesting that the same dietary components that affect the host are those who affect the microbiome. And when we want to design a diet, it makes it much easier when the same dietary components are those that we should reduce the exposure to. So in 2011, Professor Ari Levine developed the Crohn disease exclusion diet. And the main mechanism and the most important principle of the diet is the exclusion of those dietary components that are potentially pro-inflammatory. In addition, the diet comprises from food with reduced exposure, mandatory foods, which are there in order to support the patient and in order that the patient will have a balanced diet, and also to make sure that we try to improve his microbiome. In addition, there are some allowed foods without unlimited that they consume. So usually we recommend the diet with 50% of the partial 50% of the energy requirement from partial enteral nutrition. So the Crohn disease exclusion diet is a sustainable diet. it's multi-seasonal and has a progressive exposures, which means that every 6 weeks it gets easier and patients are able to maintain the diet for long term. There are no regional limitations, and now since we published and the Model Life program have started, we can see that it's been used all over the world. This is a balanced diet which allows growth, and it's also a palatable diet, which is very important because patients then can follow the diet and adhere to the diet. They have some recipes and support program that they can help them. And it's important to keep it balanced, which, as I mentioned before, the main mechanism is the reduction in exposure to the dietary components that are potentially pro-inflammatory. So we reduce exposure to animal unsaturated fat, taurine, wheat, heme and iron, emulsifiers, maltodextrin, carrageenans, sulfites, and dairy products. On the other hand, as I mentioned, we want to encourage patients to have a nutritional balanced diet, and we make sure that they have high quality of lean protein sources, and also fruit and vegetables and resistant starch as a substrate for short chain fat in order to produce the short chain fatty acids. And in 2019, just recently in recent August, we published our first randomized controlled trial using the Crohn disease exclusion diet, and it was published in Gastroenterology. And here you can see the cover figure. And what we did in this study, we compared 6 weeks of exclusive enteral nutrition to 6 weeks of the Crohn disease exclusion diet together with partial enteral nutrition using modular in this case, and both groups just followed by a reduction of the partial enteral nutrition to 25% with the CDD phase 2 or free diet. And what we found out, and I guess you are familiar with the result, that they achieved a high remission rate within the first 6 weeks, and we can see that the CDD group achieved 75% and the EEN almost 60% of patients who obtain remission at week 6. And what we do try to ask ourselves now is, can we predict who will obtain remission using dietary treatment with both treatment? So the ideal way, if we had some biomarkers that we can just assess at the beginning of when the beginning of the disease, and then to decide if patient is about to respond to dietary therapy and to be considered as a dietary responsive patient. And of course, that the goal at the future is that we have a personalized approach with personalized nutrition, and we can adjust the diet for each patient, maybe based on the microbiome, the genetics, and all other things in the picture. But unfortunately, we're not there yet. But we do know, and we have knowledge that we know that dietary treatment can cause a rapid response. So the question that we are asking ourselves now, can we use short course of dietary treatment as a marker to understand and to predict if patients will respond at later stage and obtain remission at week 6? We do know that medical treatments such as anti-TNF agents and also steroids will induce a rapid response within the first 2 to 3 weeks. But we also know that exclusive enteral nutrition will also induce a rapid response within the first 2 to 3 weeks. So what we wanted to do here, we wanted to see if in our cohort, based on the first randomized control trial, if we can see if patients will also respond rapid to this dietary program. So we have utilized the data from week 3, and what we found here was kind of amazing, because in terms of response, we saw that more than 80% of patients responded already after 3 weeks, and 63% of patients obtained remission already at week 6, which is amazing. And it's including a total cohort, which means both exclusive enteral nutrition and the CDD plus partial enteral nutrition. And when we assessed for normal CRP and remission, we saw that almost 50% of them already obtained it by week 3. So if diet do trigger the inflammation potentially, and we know that there are many patients who will respond high proportion of them, and they will respond rapidly. So maybe we can use the short course of dietary treatment, and then it will as diagnostic tool in order to decide if patient is a dietary responsive patient. And if patient do respond to dietary treatment, we can give him some information that he can control his disease for the rest of his life. On the other hand, if patients do not respond to dietary treatment, there is no reason to continue and to avoid and exclude several components that makes it difficult for him, and he should move on to the next treatment. In addition, we saw that there are also therapeutic implementation when we demonstrated in the first trial when they had a sustained remission at week 12. Later, we want to assess if there was a difference between both groups, between the CDD and between the EEN. And what we do see here that there was no significant difference between the CDD with partial enteral nutrition or the exclusive enteral nutrition. And you can see that both of them had a high response rate within the first 3 weeks, with remission without any difference, significant difference between both of them, and the same for the normal CRP remission. And here we can see the significant reduction in pediatric Crohn disease activity index after 3 weeks and after 6 weeks in the CDD plus partial enteral nutrition group, EN group, and also in total cohort. We can see the same significant reduction in CRP levels as a marker for inflammation, and it's not only the clinical aspect that we can see. We can show already that it affected after 3 weeks with a significant reduction in CRP levels in the CDD group, the EN group, and in total cohort. So the main question that we ask ourselves at the beginning is, can we predict who are those who will obtain remission at week 6? So we assess the percentage of patients who obtain response within the first 3 weeks. So out of those 85% of patients who had a response at week 3, we can see that 70% of them obtain remission at week 6, which means that 3/4 of them obtained remission at week 6, most of them. So it shows us that we can use it as a tool in this short course, the 3 weeks, and to decide if patients will obtain remission or not. So we can see that the short course of dietary treatment can be used as monotherapy for induction of remission at disease onset, and that's what we show in the first trial. We also demonstrated that it can be used in patients who are failing their maintenance therapy when we published our case series with patients who failed anti-TNF, and we provided them with dietary treatment which induce again a remission. But it can also be used as a bridge to biologic treatment when we know that there are some regulatory issues that should be solved at the beginning. So maybe we can provide patients with 3 weeks on short course of dietary treatment in order to decide if he is a dietary responsive or not. Then we assessed among the patients who were in remission at week 6, and we wanted to see how many of them obtained response at first 3 weeks and how many of them were in remission. So we can see that out of those patients who obtained remission at week 6, 94 of them already responded at week 3, with 81% of them who already were in remission at week 3, which is kind of amazing. So later, we wanted to perform a multivariable analysis, including remission at week 3, gender, CRP, and poor compliance. And we wanted to search the variables that will be significantly associated with remission at week 6 or with week 12. And we found that the variables that were associated with remission at week 6 were remission at week 3, which obtained in 81% of patients, and it had an odds ratio of 6.37, and it was significant. On the other hand, we saw that poor compliance reduced the odds to obtain remission at week 6, with an odds ratio of 0.75, also significant. In addition, the variables that were associated with remission at week 12 were only remission at week 3 for both dietary treatments with odds ratio of 4.5, and it also had reached significant. So to conclude, we saw that the diet plays an important role in the pathogenesis and the management of Crohn disease. We saw that dietary treatment, including exclusive enteral nutrition and the Crohn disease exclusion diet with partial enteral nutrition, can induce rapid response within the first 3 weeks. We demonstrated that around 80% of patients that obtained remission do so within the first 3 weeks. We saw that response to dietary treatment at an early stage increases the likelihood to obtain remission at week 6. Now, we understand that identification of dietary responsive patients at early stage will provide the patient with additional tool in order to control their disease by just manipulating and modifying their diet. And we know that dietary therapy can also be used as a standalone therapy, as a bridge to biological therapy, and also in patients who are using medication. So for the end, we suggest that an early trial of dietary therapy with the Crohn disease exclusion diet and partial enteral nutrition or exclusive enteral nutrition after diagnosis, it may be warranted in patients with uncomplicated luminal disease in order to identify dietary response, and which allows us more personalized therapy and the option for dietary modulation as part of the therapeutic strategy in the future. And I invite you all to see our recent publications and the study that was published in Clinical Gastroenterology and Pathology, and it's available online now. And with that, I would like to thank you all for listening, and I will be happy to answer any of your questions that you have. Thank you very much.
It's a pleasure to speak to you today, and thank you, Professor Leonetti, for chairing and Nestle for hosting the symposium. I'd also like to thank the previous speakers and, of course, you for your attendance. Obviously, I would have preferred to be with you in person in Copenhagen, but thanks to technology, we're at least able to continue and have the symposium. And today I will speak to you about the translation of theory to practice and the clinical use of the Crohn disease exclusion diet using real-life cases. I'll first start with a bit of a bridge from the previous talks by reminding us of the theory behind the Crohn disease exclusion diet. I'll then spend some time on the established indications for using the Crohn disease exclusion diet, focus mostly on pushing the boundaries. So how can we use this diet beyond the common indications that we're now aware of? And I'll tell you a little bit about the active research and future directions looking into this. So as you heard from the previous speakers, and Professor Leonetti set the stage very well, showing the theory behind the removal of the offending foods. And then Rotem Segal-Bonnet did an excellent job in showing us the practice. So how the Crohn disease exclusion diet randomized control trial was able to provide the very important conclusion that this diet plus exclusive enteral nutrition was better tolerated than exclusive enteral nutrition alone, but this was specifically shown in children with mild to moderate Crohn disease. And the question that we're asking now is this indication the only one, and can we look beyond that to try and figure that? So before we do that, it's important to reemphasize what the RCT looked at, and using the inclusion and exclusion criteria included in the study, we're able to answer who is most likely to benefit from this. So the inclusion criteria certainly state the pediatric age from 4 to 18 years old, mild to moderate disease with a pediatric Crohn disease index of 10 to 40. Having active inflammation appears to be very important, and that's usually evidenced by elevated CRP, ESR, or fecal calprotectin. And we also included only recent diagnoses, so below 3 years since diagnosis. The exclusion criteria mostly referred to 2 components. So being on specific therapies would exclude you, and that mostly included steroids and biologics. And then the disease location, so presence of perianal or primary colonic disease, was excluded as well. And what really guided this was the experience that we've all had with exclusive enteral nutrition, but also the experience that mostly Professor Levine, who designed the Crohn's disease exclusion diet, came up with over the years, as well as the scientific rationale that has been reviewed previously. But the question we're asking is, could this really work for other patients and other indications? And these are just some examples of those indications that I think we should be considering. So, for example, severe luminal Crohn disease. Is there any reason why we should not be using this in that setting as well? What about using it for longer than the 12 weeks, which are included in the RCT? Adult patients with Crohn disease, could they be candidates as well? What about patients who are refractory to biologics and, just addressing the exclusion criteria that I mentioned earlier on, how hard and solid are they? The other question that we would ask, which is very much related to that, are there certain scenarios where the diet could be used as an adjuvant therapy in addition to additional therapies to get the maximum effect? And I think we all have some experience doing that with the exclusive enteral nutrition. And then could we really apply some of the principles that we've seen with the CDED to all of our patients, at least to a certain extent? And indeed, we're already seeing that there are some publications highlighting the importance and the role of our dietary therapy and additional therapies. For example, from the International Organization for the Study of Inflammatory Bowel Diseases, we see this publication, which came out just in May in Clinical Gastroenterology and Hepatology, and it really summarizes the dietary guidance. A lot of the principles used for the CDED are available in this paper as well, and some of us have been fortunate enough to be part of this important exercise. There are also additional papers, such as the one by Professors Levine, El-Matari, and Van Limbergen, shown over here from Nutrients, which highlight a lot of the aspects that we're discussing today, so different uses of this diet in different settings. And indeed, there are a few ongoing studies that are addressing this in a more formal way. What I'll be focusing on now is more our personal experience, since these studies are ongoing and not yet published. But on the left, you can see the diatomic study, which many of us are involved in. This is a study focused on the more severe spectrum, so we're including patients with higher PCDAI than in the original RCT, and it's also looking at longer term therapy. And the first patient I'll show is actually a patient who's included in the study, and it probably will take another year or so until we have results to publish from this ongoing RCT. But on the right, you can also see an adult focused CDED study, which is now underway, and Dr. Levine is one of the leaders of this. Both these studies are international studies, which are happening in several countries, which obviously adds to the generalizability of the findings that we're hoping to show with these studies. So I'll start with the cases now, and the first case is a child that I've been following for the last few months. He presented at the age of 12 years, and interestingly, he has a brother who is about 3 years older than him and presented a couple years ago with severe Crohn disease, currently doing quite well on infliximab. When this 12-year-old pre-pubertal boy presented, he had a 3-month history of escalating abdominal pain, bloody diarrhea, and weight loss. He also had mouth sores and fatigue, and he was classified more on the severe side with a PCDAI of 45. You can see the inflammatory markers, which are increased, both CRP and ESR. ESR is close to 3,000, fecal calprotectin is close to 3,400 in this setting. He underwent the common investigation, so endoscopy showed really pan-enteric disease. His biopsies were positive for granulomas, and the disease was most severe in the terminal ileum. He underwent point-of-care ultrasound as well at diagnosis, showing a long segment of terminal ileum, which was quite thickened at 3.5 to 4 millimeters, with some of the secondary changes including fat proliferation and loss of stratification seen in that location. So he would certainly qualify as a severe pan-enteric case of Crohn disease. We were actually able to recruit him to the diatomic study, which I mentioned earlier on, and he was started on 2 weeks of exclusive enteral nutrition, which is something we find to be a good entry point for the more severe cases. And the plan was to consider him for the Crohn disease exclusion diet, depending on how he did. At 2-week follow-up, he was in almost complete remission. He had no pain, the diarrhea had improved, the blood had resolved, his CRP was now completely normal, and the albumin was normal as well. He was then started on the phase 1 of the Crohn disease exclusion diet with partial enteral nutrition and was happy to introduce some foods into his diet. Under different conditions, we probably would have continued him just on exclusive enteral nutrition. After 6 weeks of phase 1, so this is 8 weeks into his diagnosis, he was now in complete clinical remission with a PCDAI of 0. He had a repeat ultrasound, which was now normal, and the thickened bowel, which was 3 to 4 centimeters, was now to about down to 1 centimeter. He then continued to phase 2 of the diet, and 6 weeks later, after completing phase 2, remained in complete clinical remission. Repeat calprotectin at that time was 339, and he is now on maintenance therapy. His most recent follow-up was about 8 weeks later, and he continued to stay in remission. The second case, this is a case that Dr. Levine has been following. So this is what we call a reverse paradigm. 22-year-old male who was diagnosed with pan-enteric Crohn disease at the age of 16 now presents with about a 6 weeks history of diarrhea, weight loss, anorexia, and obvious resumption of his symptoms. He was previously on infliximab and methotrexate, lost response to this, and had been on adalimumab and methotrexate for about 2 years. He was escalated to weekly injections of the adalimumab and had partial mucosal healing with that. Due to request of the family, they had stopped the methotrexate, and probably as a result, he had developed pharmacokinetic loss of response with quite low adalimumab trough levels. So this, at the time of presentation, was a more mild case, but had lost response to adalimumab. And at that point, we had advised that this patient go on the Crohn disease exclusion diet. 6 weeks later, he completed the phase 1 and was doing very well. His symptoms had completely resolved with a normal CRP. And after another 6 weeks of phase 2, we saw that the calprotectin had come down from above 600 to 228. His labs were completely normal, and he appeared to be in complete remission. Unfortunately, at this point, he was a student and he left home and was not able to maintain his diet. And at that point, he did develop a relapse of his symptoms a few months later. But at least we were able to see in this case that in addition to the biologics, this therapy can be effective in that setting. Similar cases have been described in this paper that was published in 2017 and was reviewed by Dr. Martine de Capri just a short while ago. The third case is a 15-year-old female who has had severe pan-enteric Crohn disease since the age of 5 years. She was treated initially with infliximab, with azathioprine, which was switched to methotrexate, was then moved to adalimumab and remained on the methotrexate, and was still having ongoing symptoms such as abdominal pain, vomiting, and diarrhea. When she presented to us in this case, she was hospitalized with a severe relapse and had a sufficient level of adalimumab, suggesting a pharmacodynamic failure of her therapy, and you can see that her ESR was quite high. As she was admitted at that time, she was placed on 2 weeks of exclusive enteral nutrition, and the plan, similar to the first patient, was to pass her on to Crohn disease exclusion diet. She remained on the diet for 12 weeks and then refused to continue the diet, finding that it was just a bit too difficult for her beyond that time point. So she was switched to another biologic, in this case to ustekinumab. 6 months later, she had relapse of her disease and was defined as a primary non-responder to ustekinumab. She underwent additional colonoscopy showing deep ulcerations from the rectum to the cecum and had an MR enterography, again showing large bowel involvement with thickening in that setting of quite a log segment. At that point, it was quite clear that she likely needed surgical involvement, but the long segment was certainly a concern, and her stricturing disease did appear to be quite convincing. She needed to be hospitalized again at that time, and you can see the elevated inflammatory markers and the low albumin. At that point, she was placed on 2 weeks of exclusive enteral nutrition, which was provided by a nasogastric tube, and this was followed by 12 weeks of standard Crohn disease exclusion diet with the 2 phases. She then had a repeat colonoscopy done, and you can see the images on the left showing normalization of her large bowel, but her small bowel involvement was still there, mind you, much smaller than seen before, only about 10 centimeters. She underwent laparoscopic resection with only a small segment being removed, and was then placed on adalimumab after surgery, which up to now seems to be very effective over 2 years since this happened, and she remains in remission with this. So you can obviously see that we are able to use the Crohn disease exclusion diet in many different settings. And we have to recognize that in many ways, this is one of the options that we have in our armamentarium of different treatments, and we just have to treat it that way. So like any drug, the advantage here is that there are no side effects, but we can consider using this therapy for induction and maintenance of remission. And we're also able to achieve and maintain mucosal healing, in some cases for many years with this treatment. This treatment can also be used for a wide spectrum of patients. So obviously primary therapy has been the focus of the randomized control trial, but we can also use it in cases of failure of biologic or to induce mucosal healing for different reasons. Just like other drugs, the Crohn disease exclusion diet will have primary non-responders, and we estimate that this might be about 20%. Other cases will show lots of response. In many cases, this may be related to poor adherence, but we can use this again. So we can use this as a dose escalation option. We can use this in cases where we're hoping to induce remission again, when we're switching from one treatment or another. So really, in the setting of how we may use Crohn disease exclusion diet and Crohn disease, we do have to recognize the different indications. So this could be used for induction of remission in both children and likely adults as well. We may be able to use this as an induction and maintenance therapy without any other drugs. We can use this as an option for loss of response to biologics or in severe refractory disease before requiring surgery, for example, as we saw in the third example. In summary, I would have to say that this is something we should likely be considering for anyone who has active disease at any stage of their disease, really without specific relation to the location of the disease. And this could be either short-term therapy or longer-term therapy, depending on the needs of your patient. And with that, I'll end and I'll thank you. And we're all very much looking forward to your questions at this point. Thank you very much.
Welcome everybody to this live session of this online symposium on nutritional management of pediatric Crohn's disease. We received so many questions, so we will try to address them as many as we can. Just start with the first question. Why, I think this is for Rotem. Why are frozen vegetables not allowed? And isn't unlimited rice consumption critical due to the arsenic content? This is a difficult question, Rotem.
Okay. So first of all, thank you for the questions. The first question is regarding the frozen vegetables. Currently, we don't know if the frozen vegetables are going through some processing during the preparation, and therefore during the first two phases, we recommend not to consume them. Later on the third phase, when we feel more comfortable to consume other products that might consist other additives or might go through some processing that we are not aware if they are. And therefore, we decided that during the first two phases, we will choose not to recommend to consume frozen vegetables. Regarding the second question, is a very good question when we ask ourselves as well. Currently, we don't have enough evidence to support that the amount of arsenic acid in the rice. And we do recommend patients to consume a basmati rice, which has less content of arsenic. And also, we sometimes recommend patients to cook it with a lot of water, and then the arsenic can go out. Again, we don't have enough evidence, and from our experience, currently it's safe. And of course, that it's not mandatory. So patients do not have to consume rice. They have other options, but it's true that the diet is basically contain a lot of rice, and currently this is the evidence that we have. I hope I answered.
There is a question, maybe we can answer both of us, because maybe I mentioned this carrageenan in my talk, and there is a question, should we recommend avoiding ingredients like carrageenan to prevent development of IBD in the population? So this is, I mean, I just cited some experimental model in animals. Please.
Okay, so first of all, we don't have evidence that the carrageenan that we should prevent and recommend patients from the general population to avoid carrageenan. We currently have only evidence in animal models to show that in patients who already have IBD, then we would recommend them during the first phases when we recommend to avoid all the process and all the additives. We will recommend them also to avoid it. We don't have evidence to support recommendations for general population, so I don't see a reason why to do it at this stage.
And this is another question. During phase 3 maintenance phase of CTED, no? Or after maintenance phase, if there is a flare, what is the recommendation? I don't know.
So this is a great question, and I think both Eitan and I can answer this question. Again, this is not based on studies currently, but we will probably see it in the diatomics study as well. What we are doing in practice when patients has a flare during their third phase, we recommend them to go back to the first phase, not always to 6 weeks. Sometimes it can we can decide with the patient if it goes to 4 weeks or 6 weeks, and then they can go back to the third phase. So and I think that this is a very important part, because this is a tool. Then when I explain that when patient is a dietary responsive, he has some tool to control his disease, and every time he has some flare, he can go back to the previous to the first phase, and then reduce again the inflammation. And most of the patients do react again, and it's amazing. Then they can go back to the third phase. And from our experience, I have a good, and I know that it's working, and I have a good vibe with the patients in this term.
Eitan, you present nice cases. Do you agree with that? Do you have the same?
Yes, I do, and I don't want to repeat what Rotem said very correctly, and she probably has more experience than I do with this, but a couple of the examples that I did present really do highlight the fact that, first of all, like any treatment, we need to assess whether our patients are responsive or not, and if they are responsive, they are more likely to respond again. And absolutely, we will use this as an add-on therapy in certain cases or as a retreatment. This is where this really transfers from an RCT, where we have the evidence to support it, to more of an art and experience. And that's something that we tried to share in the last talk. But over time, I believe that many of you will get that experience. But the bottom line is that this can absolutely be used for re-remission in cases of flare.
There is a simple question. Which formula are you using for enteral nutrition? Well, I remember at the beginning when we started using exclusive enteral nutrition very many years ago, we used an elemental formula or semi-elemental that was very impossible to drink, is unpalatable. So we're using nasogastric tube. And now it's very many years that we use polymeric diet that are a good taste and are accepted by most of the children and adolescents. And in Crohn's disease exclusion diet also we use a polymeric formula. So whole proteins, and the taste is much better. Another question. You recommended high fiber food, but in the diet they recommend only refined rice in the first phase. Rotem, this is for you again.
It's a good question, yeah. And we need to remember that patients with Crohn's disease do have, we do want to reduce the amount, to limit the amount of fiber. And if we need to choose the amount of fiber, we'll choose it from vegetables and fruit, which we want to encourage them to consume. They still have inflammation, and we don't want to overdose them with fibers. And if we provide rice with unlimited amount, we don't want them to consume too much rice with consistent fiber, and then that might cause them some abdominal pain and some obstructions and so on. So basically, if patients want to consume once in a while, it's okay. And we need to remember also that it has more content over arsenic when it's whole grain. But at the first two phases, we really want to emphasize that we want to encourage them to consume the fiber sources from fruit and vegetables, which are more important for us.
Then there is a clinical question. PCDA and CRP are well correlating with early response. What about calprotectin and microbiome rebiosis? I don't know, Javier, would you like to answer to this question?
Well, it's a difficult question because I have no experience with microbiomics studies directly in this scenario, so I can't give an answer. Maybe Eitan has some kind of answer because he had studied microbiome involved in all these reactions. Eitan?
Yeah, so absolutely. I'll first refer to the fecal calprotectin, and the gastroenterology paper did look at this. We did see a significant reduction in the calprotectin in response or in correlation with the treatment. This was maybe a bit slower than what we were predicting. And part of that may have been since the initial calprotectin of many of our patients was very high. But certainly percent-wise, there was a reduction that was quite consistent. The other point is that we did look at early points, and we know that for many treatments, it does take some time for the calprotectin to improve, but we do have that outcome that we're quite confident about. The microbiome was also an endpoint in the gastroenterology paper, and the interesting finding that we had there was looking between week 0 and week 6 for both exclusive enteral nutrition and the Crohn's disease exclusion diet. We did see a reduction in proteobacteria, which is a marker of dysbiosis, I guess, and that term is a bit problematic, but certainly we did see the trend towards the normal population. When those in the exclusive enteral nutrition were reintroduced to diets moving to 12 weeks, they had a repopulation of some of those proteobacteria, whereas those who remained on the Crohn's disease exclusion diet did not. So there seems to be some persistent change. Since then, together with Johan van Limbergen, we've also had work looking at the metabolites, the short-chain fatty acids, and we are seeing persistent changes. It's a very complex area, so difficult to give a simple answer, but certainly the trend is suggesting that we are seeing an improvement in the microbiome, which is very much related to our hypothesis on how the diet might work.
Okay, then there is this question, among the potential target patients for Crohn's disease exclusion diet plus partial enteral nutrition, what about patients with confirmed stricture? I mean, this is one problem we have always, to discriminate between inflammation and fibrosis. Maybe I think the potential of acting of the diet against the inflammation can be affected, but nothing is about fibrosis. So if you have a fibrosis, then you have to go to surgery. Anyway, I think it is very important to ameliorate the nutritional status when you have to go to surgery. So, and a liquid diet can help. I don't know, what do you think, Javier and Eitan, about that? What do you do if you have a patient with a stricture?
Well, I agree with you that some patients that with very clear stricture or fibrotic stricture maybe seems not to be the best candidate to do it as a proper treatment. I mean, not as a supportive from the nutritional point of view. But I mean, it's an option. I mean, it depends on the general status of the patient. I mean, after all these studies with modified diet or Crohn's disease exclusion diet, one of the things that has opened our eyes is that every patient can be a candidate. I mean, you can try in many other patients that previously wouldn't consider for this. So, of course, if you have a quite affected with a long delay in diagnosis and you find clear images at MRI of strictures and dilation, previous dilation, so it seems, what I think it's reasonable is to be very active, and then you can try exclusive enteral nutrition or diet or partial enteral nutrition and Crohn's disease exclusion diet, but don't delay other things you could do. I mean, do it in a very close follow-up. Try to check for response, and if you don't get the target you are looking for, then try to change and go further and try another treatment more effective.
So just to add on to that, sorry,
Yes.
I agree completely. I think that one of the reasons, and this is maybe building on what Rota mentioned earlier on, that the phase 1 is quite low in fiber is because of that concern of stricturing disease. So again, if we look at the RCT, we excluded patients who had obvious stricturing disease, who had either B2 or B3. They were not included because we know that the likelihood of success is lower. But I also agree with what you said, Javier, that we are now in a position to use this treatment more extensively. There are some patients where I would initially try with just a liquid diet for the first week or two to settle things down, see how they do. And then if we see an improvement, we use ultrasound quite a bit for that. So that's a useful tool. But even if we see a symptomatic improvement, I would likely introduce the Crohn's disease exclusion diet in that setting after a couple of weeks and see whether or not that will settle down the inflammation. We have to remember the advantage of not having the side effects and immunosuppressive effects that other treatments have. But certainly there are cases where we don't hesitate to go to surgery or use anti-TNF if needed. And this is where the experience over time hopefully will guide us more.
Yes, and I think if I can add, all of us had some experience with some patients that you think they are going to surgery directly, and at the end of the day, with one treatment or other, you can control the disease, you can diminish the inflammation, modify the images in the ultrasound or MRI. So why don't try?
I would just one comment. Again, what we are doing as well is recommend for around 2 weeks of EEN. And if patient is about to go to surgery, again, EEN before surgery will we know that it's much better than to do it without. So we would recommend anyway to start with EEN to see what the decisions are going to.
And for that, there's good data in adults too, by the way, for using EN before surgery.
Absolutely. And then in the COVID-19 time, we could not avoid the question about that. So Aspen and Espen have raised concern about the use of immune suppressive drug as a potential risk for COVID-19 and cautious with the use of anti-TNF needed. We had a position paper, no? Javier, would you like to answer to these questions?
Well, as you said, we did the position paper that was quite clear, having in mind what was have been shown until that moment. So I think there is no data that says that the treatment we use in our patients, both of course exclusive enteral nutrition or diets and other treatments, put them on a risk of infection or more severe infections if it happens. So I think, well, this situation, as I told in my talk, in this new situation, we have to change many of the things we did, and we have to adapt to the new situation. And the more power we give to our patients to control the disease by their own, I mean, with less needing to go to the hospital, less needing to come to receive treatments or whatever, I think it's good for them. But I'm not really concerned on treating our patients with the drugs we have if they need it. But the thing is this gives more strength to our usual treatment using exclusive enteral nutrition or diet first in our patient as a first option.
There are questions are still coming. There is a question for you, Eitan. Why to use adalimumab in the last patient after surgery? It did not work before, even with FAB level. Thank you.
So obviously, every case will be a bit different. And in this case, really looking back at the history of the patient, and I didn't go into too much detail, it seemed that was a treatment that was most effective over time. So the rationale here was that we would get a bit of a debulking effect with the diet and bring the inflammation again under control, get the patient into remission, and set them up for more success with the treatment that they're most likely to respond to. And in a way, we do that with surgery sometimes. So there are cases where patients undergo resection, and they may go back on the treatment they were on before that they developed the complication on, just because we feel that's the most likely in that setting. And it really is a clinical judgment for each case.
There is a question: is there any comparative knowledge about mucosal healing between the Crohn's disease exclusion diet and pharmacotherapy, such as biologics or steroids? This is a difficult question. Anyway, we have data on calprotectin, no? That is, in some way, I saw in the paper in gastroenterology that calprotectin level may lower with the Crohn's disease exclusion diet, whereas exclusive enteral nutrition go back, but they are not statistically significant. Do you have any experience about that? We did not have data on endoscopy, but
I would just say that we have two studies. First, the study in adults that we are about to finish, but we were about to complete. We completed the enrollment actually, but there it's only comparison between the CDD and CDD with partial enteral nutrition. But more interestingly, we have a study that is about to start, the Paradise study in France, Israel, and Amsterdam. And then we will compare the CDD to steroids, and we will measure with the capsule, and also we'll have data to compare and to see if the dietary treatment is comparable to steroids in terms of mucosal healing. So we should wait.
Yes, absolutely. And I'm sure that is much better than steroid, because we know steroids we don't have mucosal healing, but just...
Maybe, Paolo, I can add to that too. Sorry, 2 points. First of all, the diatomic study that I mentioned, we have a voluntary endoscopy. So not all patients, this isn't part of the protocol, but for those who are going repeat endoscopy, we will have data on mucosal healing at about 6 months' time. And we don't expect that will be able to give a statistical significance, but we hope to see a signal there. I will also mention that the PLEASE study done in the USA and Canada a few years ago compared anti-TNF to exclusive enteral nutrition and partial enteral nutrition. And the experience from there did show that anti-TNF in that setting did reach mucosal healing faster than exclusive enteral nutrition. This was not Crohn's disease exclusion diet. So I think we have to recognize that every treatment has advantages and disadvantages. And I expect that if we were to compare the diet to anti-TNF, we may find differences in the rate of reduction of calprotectin. But for me, what's more important is the more long-term outcome. And if it takes a couple more months to get there with a safe treatment, then I think that's something to consider. But we will have all these data to help us make the decision over time. That the evidence is just lacking at this point.
Okay, I think we do not have time to answer to all questions. There is a final question by Richard Russell, the head of the Porto group, our group of ESCVAN. Good day to the panel, and thanks for your presentation. There seems to be practice creep for using TED as maintenance therapy on its own. Does it work? I think it does work in some way as a maintenance therapy. What do you think, Rotem?
Okay. First of all, I have to say that currently the data that we have is for the maintenance phase, it's based only on our experience. We do have two studies that Eitan showed earlier, the one in adults that is investigating the diet for 6 months, and also the diatomic study that we will probably have the result there also to compare the CDD for 6 months, and then we will have data for the maintenance phase. But I have to say it's very challenging. The maintenance phase, patients can go back to have some free meal, and they choose what to eat during the free meals. So it's kind of challenging to decide how to do it and how to investigate it. I have to say that basically the idea is to educate the patient to maintain some kind of restrictive diet, but to go to eat in restaurants and to eat normal life, and to find the balance. That's what we're trying to educate the patients, to change their lifestyle. And I think that's what at the end will help us to know.
Maybe
Okay.
Sorry. Maybe I could just add one
yes,
more.
Yes, please.
So this is really where, as Rotem said, our experience is probably the predominant source for this. I have to say that there is some fatigue from patients being on the maintenance diet, even though it is more liberal. Some of them just can't do it over 6 months or longer, and we have to accept that, right? It does have the limitations. Certainly for some children, this is a bit more difficult. Some of them are just loving it and they'll stay on it. But I think even if we are getting some partial response and it's minimizing our need for additional therapy, so if we can get along with less adjuvant therapy, then that's an accomplishment as well. Even if we get the effect that we get with exclusive enteral nutrition of not needing steroids and allowing us to complete the workup and start the patient on another therapy in a better situation, that's a good enough reason to do it. But for some, it can be used as a maintenance therapy. We just don't have enough data yet to tell us who will be in that situation.
Okay, so thank you everybody for attending such an interesting online symposium. I would like to thank Nestlé to organize this, and unfortunately could not answer to all the questions we've got, but the remaining questions will be addressed on the website. So bye-bye everybody, good afternoon or good night, depending where you are.
Thank you very much.
Thank you, everyone.
Thank you.
Bye-bye.
Bye-bye.
Bye.